My name's Hervin. I'm one of the registrars at UCT. The topic of my presentation this morning will be on submandibular sialolithiasis. Consent was obtained from the patient, and all my content is referenced. My case is of a 51-year-old female who presented with a 5 months history of recurrent painful periprandial swelling of the right submandibular gland. She was successfully treated with antibiotics. On bimanual palpation, a mass was palpable along the right submandibular duct. A CT scan done showed a 1 centimeter right submandibular calculus in the floor of the mouth, and the patient was booked for calculus removal in 6 weeks under general anesthesia. The floor of the mouth was infiltrated with xylocaine with adrenaline at the site of the planned incision. The mucosa directly over the calculus was incised with a 15 blade. The calculus was identified and removed, and the opening in the duct was marsupialized by suturing the cut edges of the duct to the oral mucosa with interrupted foravicular sutures. The patient was subsequently discharged home on the same day and recovered uneventfully. So my presentation today will be focused on submandibular sialolithiasis. Sialolithiasis is the most common disorder of the major salivary glands, accounting for 50% of major salivary gland diseases. Approximately 80% of sialolithiasis involves the submandibular glands, 20% occurs in the parotid gland, and less than 1% is found in the sublingual gland. Patients with obstructive sialidinitis present with a history of recurrent, painful periprandial swelling of the involved gland. Conservative management is with sialogogues, massage, heat, fluids, and antibiotics. When these fail, then sialolithiasis needs to be surgically treated by transoral, silendoscopic, and silendoscopy-assisted techniques, or as a last resort, sialidinectomy. Sialoliths vary in size, shape, texture, and consistency. They may be solitary or multiple. They are composed of both organic substances, including glycoproteins, mucopolysaccharides, and cellular debris, as well as inorganic substances, which consist mainly of calcium carbonates and calcium phosphates. Other inorganic components of sialoliths include minerals such as calcium, magnesium, phosphate, manganese, iron, and copper. The organic substances often predominate in the center of the stone, while the periphery is mostly inorganic. While the pathogenesis of sialolithiasis is unknown, 2 major hypotheses have been proposed. Some speculate that intracellular microcalculi excreted into the canal may become a nidus for further calcification. A second hypothesis, known as the retrograde theory, suggests that food debris or bacteria in the oral cavity can migrate into the salivary ducts and become the nidus for further calcification. Risk factors commonly attributed to salivary gland stone formation include dehydration and smoking, use of diuretics and anticholinergic medications, a history of gout or trauma, and chronic periodontal disease. Salivary stones occur predominantly in the submandibular gland, likely because Wharton's duct has a longer course, upward salivary flow, and increased alkalinity and viscosity of the saliva when compared with Stenson's duct. The mean size of submandibular stones is 7.3 millimeters, with an average growth rate of around 1 millimeter per year. Stones greater than 15 millimeters in size are considered giant. salivary gland calculi. The majority of submandibular stones are located in the distal third of the duct or at the hilum of the gland, while pure intraparenchymal stones are infrequent. And the location of submandibular stones is important for guiding management. Sialolithiasis is primarily a clinical diagnosis based on patient history and physical examination. Patients commonly report a sudden onset of swelling and pain in the affected gland that is associated with eating, referred to as mealtime syndrome. Acute sialidinitis in the setting of sialolithiasis presents with pain, swelling, and erythema around the gland. Fever and chills may also be present. Bimanual palpation, that is, finger inside and outside the mouth, is especially important when examining the submandibular gland and its duct. Palpation of the floor of the mouth in a posterior to anterior direction may allow the sialolith to be seen at the opening of Wharton's duct or palpated along its course. The gland itself may be tender to palpation, especially in the presence of sialidinitis, and there may be purulent discharge at the orifice. Compression of the salivary gland should cause clear saliva to flow from the associated duct, and if this does not occur, a stone may be obstructing salivary flow. Aside from patient history and palpation of the duct, various imaging techniques are available for the diagnosis of sialolithiasis. Imaging can identify a sialolith, an abscess, or mimickers of sialolithiasis, such as neoplasms. Imaging modalities include plain X-rays, sialography, ultrasound, and CT scan. With plain X-rays, approximately 20% of submandibular stones are not visible. In the first picture, we can see a calculi within the duct, and in the picture on the right, we can see a calculus within the submandibular gland. Note that plain X-rays have less value with parotid stones because of the higher percentage of about 60 to 70% of radiolucent stones. In conventional sialography, the duct is cannulated and a radio-opaque dye is injected before plain films are taken. It is quite rarely performed today, and it provides images of the morphology of the ductal system and allows the diagnosis of strictures, dilatations, and filling defects. The sensitivity of sialolith detection ranges from 64 to 100%, while its specificity ranges from 88 to 100%. With the use of subtraction, the sensitivity of stone detection increases to 96 to 100%, while specificity is 88 to 91%. The disadvantage of sialography includes exposure to ionizing radiation and iodine contrast media, pain during contrast medium insertion into the salivary ducts, and calculi dislodgement towards the gland. The quality of the resulting image depends on the experience of the operator performing the cannulation and the sialography evaluation. The technique is also associated with several complications, including salivary duct perforations, inflammation, adverse reactions to iodine medium, and bleeding. It is contraindicated in patients with acute sialidinitis or contrast allergy. Magnetic resonance sialography is a non-invasive alternative to conventional sialography. It may also be carried out during acute inflammation of the salivary gland. The sensitivity and specificity of magnetic resonance imaging sialography are reported to be 91% and 94 to 97% respectively. The main advantage of MR sialography are the precise evaluation of the salivary duct, including proximal branches, and the detection of very small stones. And it allows concomitant evaluation of the salivary glandular parenchyma. The drawback of MR sialography is that it is expensive and not widely available, especially in resource-limited settings. The diagnosis of sialolithiasis is almost entirely indirect, relying on findings such as ductal obstruction with signal loss and also on prestenotic dilation. Note that dental amalgams may lead to distortion artifacts. Ultrasound is another frequently used modality for the diagnosis of submandibular sialolithiasis. Sialoliths typically appear as echogenic, round or oval structures, producing an acoustic shadow on ultrasound, as you can see in the picture. Stones may also lead to proximal distension of the duct, which may be seen on ultrasound. The detection of fine stones may be helped by lemon juice or sour sweets, which cause salivary duct dilatation and hence facilitate sialolith visualization. Ultrasound is mostly suited for stones larger than 2 millimeters, greater than 90% of which can be detected by ultrasound. Stones smaller than 2 millimeters may not produce any acoustic shadow and are therefore difficult to detect. Ultrasound has been reported to have a sensitivity ranging from 59 to 94% and a specificity ranging from 87 to 100% for the detection of submandibular sialolithiasis. The advantages of ultrasound include its non-invasive nature, relatively low cost, and the lack of radiation exposure. The disadvantages include the need for an experienced operator and low sensitivity for detecting salivary gland neoplasms or stone-related complications such as strictures. High-resolution CT of the neck is one of the most commonly used modalities for the evaluation of salivary stones. Most stones are visible with non-contrast CT, and fine cuts should be used so that small stones are not missed. Non-contrast CT has a specificity of 98% and has a sensitivity of 98% and a specificity of 88% for salivary stone detection. The two main drawbacks for non-contrast CT imaging are that it exposes the patient to ionizing radiation and provides less detail of ductal dilation and the length of a stenotic segment. We'll now look at treatment options. Conservative management is often the mainstay of treatment in the majority of patients. Patients should be instructed to maintain hydration, apply heat to the involved area, use non-steroidal anti-inflammatory drugs to reduce pain and inflammation, and massage the gland to produce ductal outflow. Non-pharmacologic agents that promote salivary flow, such as lemon juice or sour sweets, may be helpful. If sialidinitis is suspected, anti-staphylococcal antibiotics should be administered. Ultrasound or CT imaging with contrast may be performed if there are signs suggestive of an abscess, such as fluxions, erythema, and warmth. The objective of interventions for submandibular stone extraction is generally to save the gland. Patients with recurrent episodes of sialolithiasis should be considered for operative management due to the risk for chronic sialidinitis and loss of glandular function. Patients with sialidinitis that worsens or shows no improvement with antibiotics also require operative evaluation, as they are at risk for the development of salivary gland abscess and spread of the infection to the floor of the mouth, which can potentially lead to airway compromise. In general, stones measuring less than 5 millimeters can be removed with salendoscopy using a simple basket extraction. Stones between 5 and 7 millimeters may be removed either with combined salendoscopy and transoral surgery or using laser lithotripsy with salendoscopy. Stones larger than 7 millimeters and those near the hilum or partially inside the gland are amenable to combined approaches. Silendoscopy is especially useful for mobile stones, which are less than 5 millimeters, lying freely in the duct lumen. And these can be extracted without additional interventions or fragmentation in greater than 80% of cases. Siloliths may be mechanically removed by using either a basket, mini forceps, a grasper, or a balloon. Several factors are involved in choosing an instrument, including the mobility of the stone, the connection to the ductal wall, the size, and the ability to bypass the stones. The overall complication rate has often been reported to be around 3%, and this includes ductal strictures, perforations, granular formation, lingual nerve injuries, infection, and bleeding. Submandibular stones between 5 to 7 millimeters in size may be fragmented in the duct lumen. Usually a holmium YAG laser assisted lithotripsy is used. The major advantages of this method are the indirect visualization of the stone, as well as assessment of the ductal system before, during, and after the intervention. However, there are still risks of perforation, stricture, and thermal injuries to nerves and vessels with this technique. Extracorporeal shockwave lithotripsy is a technique that permits fragmentation of stones of any size and location, which are then excreted either spontaneously by salivary flow through Wharton's duct or manually with silendoscopy. Since it is performed as an in-office procedure, it offers several advantages other than over other interventions, in that it is easy to perform, it is repeatable and well tolerated. However, it is not available or approved for calculi removal in several countries. The main drawback is that stones often cannot be completely cleared by salivary flow, and residual fragments can cause recurrences. Intraoral silolithotomy approaches are generally used for palpable stones up to the first molar tooth. It can be done under local or general anesthesia, but one must be mindful that in the anterior floor of the mouth, the lingual nerve is located posterior to the duct, and it crosses deep to the submandibular duct in the lateral floor of the mouth. Local anesthesia with a vasoconstrictor is administered in the floor of the mouth at the site of the planned incision. 2 3/0 silk sutures are placed around the duct posterior to the stone to isolate the stone and to prevent displacing the stone to the proximal part of the duct or to the hilum of the gland. And the mucosa is cut directly onto the stone with a cold blade. Electrosurgery and or carbon dioxide laser have also been described, and the calculus is removed. The opening in the duct may be marsupialized by suturing the edges of the duct to the oral mucosa with interrupted 4/0 vicral sutures. However, one should note that the same silolithotomy procedures for the more posterior ductal region carry a significant risk of injury to the lingual nerve and the possibility of severe bleeding from the lingual vessels. Larger submandibular stones, that is those usually more than 7 millimeters, as well as those that are difficult to access with silendoscopy alone, such as intraparenchymal and perihilar stones, can be removed using a combined approach, pairing silendoscopy and transoral stone removal. This technique involves the use of the silendoscope to localize the silolith before performing transoral surgery for stone extraction. Silendoscopy can again be performed after stone removal to check for additional siloliths and to remove stone remnants. Saladenectomy is performed where combined or minimally invasive approaches are not successful, or in patients with recurrent stones. The transcervical approach to submandibular sialidectomy is the most common approach described. And the key concerns for the patient are the surgical scar and injury to the marginal mandibular, lingual, and hypoglossal nerves. There's an excellent chapter on submandibular salivary gland excision in the open access atlas of otolaryngology, head and neck operative surgery, which I would highly recommend reading. So in the conclusion, with the introduction of minimally invasive techniques for stone management, even larger sialoliths can now be removed with minimal surgical morbidity and high gland preservation rates. But of course, the techniques used depend largely on the resources available. These are my resources. Thank you.
Very nice. Very nice presentation. Yeah. You're the audience.
Yes.
Next. Nice presentation. I'm glad you mentioned the sialolithiasis. I think people are getting quite fixated on doing everything with the endoscope now, and then when that doesn't work, jumping to removing the gland or getting what's in between, and also relatively less invasive and less risk. So that case was actually referred for excision, and we got it out just by doing the cutting. Yeah, the ultrasound is probably the investigation of choice, isn't it? That's your reading as well.
Yes.
Yeah, MRI would be overkill, I think, and we don't do contrast studies anymore. You find that the radiologists just don't have the skill set anymore. You really feel that every candidate of that. So you're not going to find many radiologists that will do that with you. So it's almost historical.
When it comes to sialolithiasis, later to say to use anti-staphylococcus agent. So, what molecule do you use openly for salivary gland infection?
Yes.
Yeah. But you can open that. Yeah. So, antibiotics.
What antibiotic for acute sialolithiasis would you prescribe as first line?
Okay, we would normally give a broad spectrum antibiotics that covers both aerobes and anaerobic infection. The most commonly used one that I've seen is called amoxiclav, but
you said anti-staph in your presentation now.
yes, anti-staph.
Yeah, so is it broad spectrum or is it just anti-staph that you would use specifically?
So the recommended one is anti-staphylococcal.
That's flucloxacillin or
yes, it's called amoxiclav.
Yeah, my point is just for salivary gland infection, the macrolide molecule is eliminated through the salivary gland.
Oh.
So it is more efficient to use like rubamycin or clarithromycin for that perspective.
Okay, I wasn't aware of that.
Yeah, Vincent's on the call.
Yes, we have Dr. Pretorius on the call. Dr. Pretorius does a lot of endoscopy procedures. Dr. Pretorius, you want to comment?
Hi, Hervin, thank you. I thought that was a very, very good talk. I think I don't really have much to add. I think if you get starting off with endoscopy, I think stones of less than 5 millimeters are a little bit ambitious. I think it's important to start with the smaller ones, say 2 to 3, even 4 millimeter stones, before proceeding between the 4 and 5 millimeter ones, because in that range, you need to look at the shape of the stone and see if it's a floating stone as well. because the stones come in various shapes and sizes. I wouldn't, as a blanket rule, say any stone less than 5 millimeter is amenable for silendoscopy. And then I think you also mentioned it, but it's very important for the audience to remember that most of the smaller stones will be expelled, spontaneously.